So welcome everybody to the first episode of The Animal Heartbeat. My name is Kieran Borgeat. I am a specialist in veterinary cardiology, and I'm here with my friend and esteemed colleague, Novo Matos, who is also a cardiology specialist. We're here to talk to you about veterinary cardiology. So if you're not interested in veterinary cardiology, then, you have no soul, and that's fine, but you don't have to listen to us anymore. We're here to discuss a few things today around the topic of feline cardiology. Jose, have you ever learned about heart disease in cats before? Is that something you've ever come across?
Not really. This is really the very first time. Thanks for listening. I'm very excited to record this podcast with you. I love feline cardiomyopathies. We both do, and are by far the most interesting heart diseases we see. So very excited to talk to you about this topic. Yeah.
And I think part of the interest for me is the challenges that cats present, partly as patients, but also in their heart disease, isn't it? I mean, I'm a novice at this. You have a PhD in feline cardiology. So what do you think are the biggest challenges about feline cardiomyopathy?
Yeah. What I think is very cool, cats per se are very, very good at hiding clinical signs and hiding signs of disease or weakness. And then on top of that, the most common heart disease in cats are cardiomyopathies, which by definition are challenging to diagnose because both in humans, cats, dogs, they have a very long subclinical asymptomatic stage where no one can really detect the disease, neither their owners or vets. And so it's very, very challenging because cats may look very normal and they may have a very nasty and advanced heart disease. So I think that's one of the very first challenges to know which cats might have advanced heart disease and just look pretty normal.
One of the biggest challenges, I think, about detecting heart disease in cats is that often as vets, we focus on the presence of a heart murmur as being indicative of there being heart disease. And I think most vets now understand that's not always true in cats. What's your experience of heart murmurs in cats and how reliable they are as an indicator of heart disease?
So the challenging thing is not all cats with cardiomyopathies will have a heart murmur. And so the fact that cardiac auscultation is completely normal will not exclude that a cat might have heart disease. And
Sure.
So a normal cardiac auscultation does not exclude the disease. Which, as you were saying, I think vets understand that and are aware of that. But the crazy thing really is that some normal cats will have heart murmurs. And so some healthy cats will have heart murmurs, which are called physiological or flow murmurs. And so it's really challenging because you may detect a heart murmur, which might be physiological or benign. And on the other side of the spectrum, you may not detect a heart murmur and the cat may still have heart disease. And so murmur grades matters in this case.
Okay.
And so I think what we generally recommend vets to do is to grade heart murmurs, because it has been shown in several different studies that the louder the murmur, the more likely is that murmur to be clinically significant, to be relevant. And so I think the question is not, is there a heart murmur, but more how loud is the heart murmur? And if the heart murmur is louder than 3, it's likely that this heart murmur is relevant and should be pursued. On the other way around, if it is a soft murmur, is less likely to be clinically significant. Would you
3, I would. And just to sort of clarify for anyone who doesn't know about the common grading system that we use out of 6, is that 3 would be the same intensity as the heart sounds, the same volume as the heart sounds. So if it's an easily audible murmur that's the same or louder in intensity as the heart sounds, then actually I think we would both recommend following up on that and trying to work out whether there is heart disease present or not. One of the things that I really like about murmurs in cats, and there's a lot to dislike because there are lots of false positives, there are lots of false negatives when you're looking for heart disease or screening for heart disease. But one of the things I like about it is is if we contextualize the murmur in the other points of signalment in that patient, the age, the sex, and even the body condition score, this is something that can be incredibly useful. So I think the work by Rosie Payne and the RVC team in the past has demonstrated very nicely that in apparently healthy cats, and these are largely domestic short hair cats, it's important to say, in apparently healthy cats, if a cat is older and male and a body condition score 6 or above out of 9, then actually that makes it much more likely that the heart murmur indicates hypertrophic cardiomyopathy. And the reason that we focus on hypertrophic cardiomyopathy or hypertrophic phenotype in cats is that that's by far and away the most common type of heart disease that we see in that species. Very, very rare in dogs. Cats are a bit more like humans in that regard, aren't they? Where HCM is relatively common. So I think if I see a grade 3 murmur in a 1-year-old female cat, I think, okay, we've got a murmur. It merits investigation because it is a grade 3. But I'm not so worried about HCM. Now, sometimes I'm wrong about that. Sometimes we do find cardiomyopathy in that patient. But for me, those 10-year-old male, body condition score 6, 7, 8 cats, those are the guys where I really want to take that murmur seriously. And I guess when I've auscultated them, I believe there's HCM present. And what I'm doing with the echo is to look at severity. And sometimes we echo those cases and we find nothing. And we say, okay, great. It is a physiologic flow murmur. But those are the cases where really I'm going into that echo thinking, I believe there's heart disease present. Let's stage it. Let's see where we're at with this disease. Now, obviously, you and I can pick up the echo probe pretty easily because of our experience and training that we've had. But that's not the same case for all vets, is it, in terms of how confident they feel performing an echo? So we've already gone straight to talking about echo. What other options do we have available for diagnostics in those patients? Imagine, back in 2006, I was in primary care practice and I see a cat who's got a grade 3 or 4 heart murmur, 5 or 6-year-old male cat, middle-aged male cat, apparently healthy, coming for routine vaccination. What would your advice to me be as the vet in that scenario? Do you think it's worth me pulling some bloods, for example, and looking at maybe cardiac biomarker results?
Just to stress what you have just said, the problem, also the challenge is echocardiography is the clinical gold standard to diagnose cardiomyopathies. X-rays are not that useful, really. If we compare with maybe mitral valve disease in dogs, that maybe X-rays can help you. They are not helpful with cardiomyopathies, and that's where the challenge starts. Because of course, echo is expensive, is not readily available, and requires experience and expertise, and many clients will not have access to it. So it's important, really, as you were saying, to screen and or to decide which cats really are worse to echo and which cats one should echo or refer for echo. And so what you have just mentioned is really important: signalement and put together a couple of pieces to the puzzle: age, sex, and murmur. So absolutely, totally agree. And then comes biomarkers, and I think biomarkers, and when we say cardiac biomarkers, we are mainly talking about NT-proBNP or cardiac troponin I. Those were the biomarkers that have been more studied and where we have more research data on.
And those are the ones where people can access the tests, aren't they? Where they're commercially available tests.
Exactly.
We might read research about ANP or CMP or troponin T, but these things are you have to buy an ELISA kit and run those manually. If you want to run a commercially available test, NT-proBNP and troponin I are the things to use, aren't they?
Precisely, and especially now that there's a SNAP test for NT-proBNP, so everyone can get a very quick result,
sure,
positive versus negative result. But to go back to your question, I think, especially as a screening test, NT-proBNP has been shown to be quite useful. Now, what we need to be aware is we should use these tests when we already have a clinical suspicion of heart disease. Because if we just run the test in every cat that comes to our clinic, the test accuracy will be poor, as with any other blood test. So the SNAP test will give us a probability for heart disease, and that's important to explain to our clients. So if the test is positive, in a middle-aged cat with a loud murmur, makes it very likely that this cat will have moderate to severe heart disease. If the test is negative, makes it less likely, the probability is lower for the cat to have moderate to severe. I'm saying moderate to severe because NT-proBNP is not very good at detecting mild disease. So all we can tell to the client is explaining them, okay, a positive test in your cat, where I already have a suspicion of heart disease, makes it likely that the cat will have moderate to severe heart disease. And then we should do an echo or refer for an echo to exclude underlying heart disease. So the test is good as the first screening, really as a screening test in cats with a high positive predictive value, when we already suspect that the cat might have heart disease. And I would just name the reasons for that: a loud murmur, middle-aged to older cat, and potentially overweight, or a familial history of heart disease, or other auscultation findings, such as an arrhythmia, a gallop. Arrhythmia and gallops are way more specific, are way more likely to be associated with heart disease than murmurs. So then if we start putting all that together, this cat has a high suspicion of heart disease, and then BNP will help us, give us that extra confidence.
I think, your point, well, there's 2 points that you said that I think are fantastic. One is about gallops and arrhythmias, because I think if I hear a gallop sound, I almost don't want to run an NT-proBNP. I just want a cardiac assessment, by which I mean an echo. The reason for that is that obviously any blood test, well, any test, in fact, could have a false positive or a false negative result. And for me, if you have a gallop sound, the likelihood of there being significant heart disease is so high that when I get an NT-proBNP result that's negative, I almost feel like it's more likely to be a false negative result in that context. I guess the way it could be a true negative is actually the third heart sound you hear. So ba-ba-bum, 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 rather than the normal lubbed up sound. That third heart sound may not represent a diastolic filling noise, which is representative of high pressure and therefore bad heart disease. It might be a valve click. And I've certainly seen those. I think probably as commonly in cats as I've ever seen them in dogs. And with dogs, we see it with very early mitral valve disease. I'm still not sure where it comes from in cats. It might just be older cats who have got diastolic dysfunction. It may be they've got a tiny bit of mitral prolapse. I'm not entirely sure, but I think we do hear those third heart sounds in some cats that may masquerade as a gallop sound. But I'm still not keen in those galloping cats to run an NT-proBNP. I think that going back slightly further in what you said, you were talking about probability. That's just so important. And I think it's such an important concept because I come across many primary care vets who will say, I was thinking about starting treatment because the NT-proBNP is high. Whoa, back up the truck. We don't want to treat based on a biomarker. I don't think I can imagine a context where I would give any cardiac treatment based on a biomarker in a cat or a dog or a horse. Do you agree? Can you think of anything where a biomarker would make you treat?
No, I totally agree. And again, I think sometimes we forget that the biomarker, cardiac biomarker, is just a blood test as any other blood test. And so it's just because the test is positive or negative, will not help us at all. We cannot guide treatment based on that. So totally agree. I don't think there is any clinical situation where you would start treatment based on the biomarker. Just to stress what you said, just to go a bit back, a gallop or an arrhythmia is indeed highly specific of heart disease in cats. Dogs may have arrhythmias, which may be caused by systemic disease, and the heart may be normal. But that's very rare in cats. When cats have arrhythmias, the large majority of cats will have heart disease. So totally agree with you. If we detect an arrhythmia or a gallop, we should echo this case. This is a clear-cut indication. But what you said is important. Sometimes I think it's difficult when I discuss with vets and residents. Sometimes it's difficult. Sometimes people struggle to be sure if there's a gallop. The heart rate is very, very fast. And as you were saying, potentially there's other heart sounds, additional heart sounds such as clicks and so on. Sometimes we receive cases which people have detected gallops and there are no gallops or vice versa. So it's not always easy. But I totally agree with you. If you're confident, if you have a lot of experience with cats and you think there's a clear-cut gallop, absolutely echo straight away. If you are not sure, would not hurt to do NT-proBNP. If you let me just regarding your point, because one could say, okay, BNP may not be 100% test, but now let's say that we don't use the SNAP test and we send it to the lab to do an ELISA, and you have a value. And then I would tell you, okay, but the value is 1,200 or more than 1,500, the upper limit of the test. Some people could think, okay, 1,500 is very, very, very high. 1,500, a very high value, has been associated with cats in congestive heart failure or close to heart failure. So cats that had very, very high values had very advanced heart disease and were considered to be in congestive heart failure or very close to congestive heart failure. But a recent study done by June when he was at the RVC showed that SAM, cats without flow tract obstruction, may have very, very high BNPs with a normal left atrium, meaning that just a very high BNP most likely is associated heart disease, but does not guarantee that this cat has advanced heart disease and is on the edge of heart failure.
And that study was definitely something in my mind when we were talking about it just now. Yeah, I completely agree. And that was a real eye-opener for me, because I think previously I'd thought, if they're super high, I'm really expecting, at least a big atrium and maybe some high filling pressure. But actually, that was a great study, again, from the RVC group, which really highlighted to me that the potential inaccuracy of NT-proBNP. They tell you, if it's that high, it tells you there are some significant changes that you're going to see on the echo, but it doesn't tell you what changes. It doesn't say that they're going to be high risk, and it certainly doesn't stage them, as to sort of B1, B2, C staging system. That the biomarker is really a supportive tool, isn't it? Do you ever use it for monitoring these cases? Let's say we already know they've got HCM, and you pull NT-proBNP and it measures 600, so it's well within the sort of measurable limits of the test, but it's above the reference of 100 or 150 picomoles per liter. What do you do with that? Is that something you ever reach for as a cardiologist, or would you ever recommend monitoring it to primary care practitioners?
So I generally don't use it as a way to monitor heart disease. And why? Because we don't really have data on daily variability. Or good data on daily variability or weekly variability on NT-proBNP in cats, as we have more data in dogs. And so I'm always concerned on what is the degree of when do you get worried? What is the magnitude that BNP needs to increase for us to become worried? So I always struggle with that a bit. And so we need more data. But having said that, sometimes we do, when we have clients that cannot afford echoes for whatever reason, and we measure NT-proBNP when we echo these cat, because then we know, okay, at this baseline times 0, we have these echo findings and the BNP of X, and then give that information to the referring veterinarian. And then it's not uncommon that they will measure then again in 6 months, and then if indeed the value increases, it might indicate that the disease has progressed. But it's challenging. It's really a challenging field because we do not have data on that. We do not know how big the increase needs to be to be clinically significant or to indicate heart disease. And I'm worried that I will give this false sense of security that will people feel, it's still 600 or 700 and it's fine. The disease has not progressed, and we unfortunately cannot say that. So I'm not sure. What do you do?
Yeah, I think I remember an abstract some years ago at ACVIM that was presented where the presenter was talking about there being up to a 70% day-to-day variability in that NT-proBNP, which almost makes it useless for monitoring because it's such a high degree of variability. You'd have to have a case that went from, well, I don't know, I'm not very good at maths. The cat would have to go from 500 to, I don't know, 850 to be a real change. I have used it for monitoring in the past. I think all of us as clinicians, but even as specialists, go through phases of what we consider to be sort of fashionable or good at a time. And when there's no data, we don't necessarily always change our ways. So I definitely went through a phase of saying to people, okay, your cat has a cardiomyopathy with a hypertrophic, maybe I'll just say HCM, phenotype, and a normal size left atrium. So we would say at that point the cat's low risk. And we would normally say repeat the echo in a year. Now, let's say either there are financial restrictions or the cat just said no and didn't want to have an echo performed. And we've had to give a little sedation, and that's challenging. What we'll sometimes do is if we identify those challenges at the time of the echo, we'll pull the biomarker and say, okay, your NT-proBNP measures 500. That's fine. Who cares what the number is, as long as it's within that 1200 or 1400, I can't remember now, the maximum interval of accurate measurement. So we say it measures 500, and we say, okay, well, when you go to your vets next year for annual vaccination, get them to pull some blood. Actually, that might be easier for them to do and less stressful than an echo. So the vet sees them for vaccination, pulls some blood, and if it measures 650, we say, it's minimal change, really. So we don't need to perform an echo again. And they go back the next year and it measures 670, and that's fine. They go back the next year and it measures off the scale. Okay, that's a callback for an echo. And yes, we acknowledge we need to sedate, but actually we've then saved 2 echoes, 2 stressful events. That may be the worst thing in the whole cat's year. So actually, that felt good to me for a while to do that. But I do agree with you. We have a complete evidence vacuum of how to use that. It would be nice to do that in a study, wouldn't it? And actually say how many cats have a heart failure event when we think they're okay. Because actually, if the proportion is very low, well, that's a great monitoring tool. But right now we don't have that data, and actually, I think it's gone out of fashion for me because I've maybe lost confidence in that as a monitoring technique. And I think the day-to-day variability probably is quite high, but I don't know what it is. So I'm telling people this is your callback level, 750 picomoles per liter, but that is something I've effectively decided, and I don't have there's no consensus on that. I don't have great evidence behind that. So just touching on that point of the challenges with echoing cats. How do you approach getting a good echo in a cat? I've recently moved jobs, and I found actually the experience of echoing cats where I am is very different to my previous job. And I think the environment is quite important, and not just the environment where the echo takes place, but the sort of lead in to that echo before we handle that patient. What are your thoughts on that, and what are your experiences?
I totally agree. I think very easily we underestimate how much the environment plays a role. And so if we can optimize the environment by this, I mean, to make the environment as cat friendly as possible, it has a major effect. I totally agree. Starting from the traveling, starting from when the cat travels to the clinic, while the cat is in the waiting room, and then how do we start examining the cat, when do we clip the cat, and so on. And also your nursing personnel or who is helping you, it plays a huge role. So I think people should not underestimate that at all and try to optimize that. Just as an example, we now, whenever we scan cats, we keep the room dark pretty much all the time. We do initially a very brief clinical exam before measuring blood pressure. We will prioritize blood pressure, and then very carefully we'll clip them if we need blood. We'll apply amla to try to reduce pain and so on associated with blood collection. So we think beforehand every step that might be stressful. Everyone speaks in a very low voice. We don't want anyone talking loud in the room and so on. We close the room. We close the door to avoid people getting in the room suddenly, and that has a major effect. Totally agree, major effect. And also to have the right nurse, the right people to help you restraining your cats. It plays a huge role. And in fact, a lot of times we end up avoiding sedating these cats heavily when we improve the environment. But yeah, there are some nice drugs out there now, isn't it? What
for the cats? Use? Nice drugs for the cats. Let's clarify.
Yes, absolutely. Thank you for that. Sure, of course. What do you use to sedate cats or to reduce their anxiety?
I'm quite a fan of gabapentin, and actually the owners giving that before travel, because I think that wind up of travel is pretty bad. And you and I, seeing referred cases will, of course, on average, see a longer travel journey. We have people come sometimes 3-4 hours to come and see us at our clinic, and that's a heck of a journey for a cat who's a bit worried about being in the car. So what we like to do is actually ask the primary vets to dispense some gabapentin. So I guess we prescribe, they dispense. The owners collect that the day before, and they maybe give a dose the previous evening, a dose in the morning, 2 hours before their sort of anticipated stressor, or an hour before travel. And that definitely helps, I think. If they come to the clinic on the gabapentin and they're still very worried, they're still very anxious, then I quite like using butorphanol. It's a bit boring because anyone who's ever heard me speak on sedating these patients or cardiac anesthesia, I love an opiate for these cases. And butorphanol is nice and cardio neutral. I don't think it does much to affect vascular tone. It doesn't really affect systolic function in a negative way. It might drop the heart rate a little bit because they're less sympathetically driven, but that's okay. And if anything, a slightly lower heart rate in a cat is going to help us get some nice diastolic function measurements on those echo images. So for me, I'm super happy with that. Occasionally, we'll see a cat who is just gone. And they either because of previous negative experiences at the vets or just the overwhelming anxiety of that whole experience. There's just no hope of getting it, even with some gabapentin plus or minus butorphanol. A good example is the hypothyroid cat, who has such a high density of beta receptors because of their thyrotoxic state, and they're so sort of driven and so worried about everything that they're kind of electric and buzzing. That those are the cases where we'll spot them and go, okay, my physical exam is going to be really tough. There's no way I'm getting a blood pressure cuff on that cat, let alone echoing them, with everything being sort of welfare friendly and safe for the cat and for the people handling. So what we all tend to do in those scenarios is actually use an intramuscular sedation, and it's quite deep sedation, and it's a combination of butorphanol 0.2 milligrams per kilo, midazolam 0.2 milligrams per kilo, and alfaxalone 0.5 milligrams per kilo. And we use that in the same syringe. In a cat, it's quite a small volume. The reason we don't use it so much in dogs is because the volume gets very big of the alfax, which isn't very nice for an IM injection. But we'll do that in our very worried cats, very fractious cats. And then once they are, within a few minutes, they get very sleepy. We'll get IV access. We always have some stuff ready to intubate, just in case. I've never had to do that. And I've been using this sedative combo since 2017. So, 6 years. And I've not had to do that, but we always prep. I think that sort of is my superstition, I guess, that prevents it from happening. And we give flow by oxygen for those cases, lubricate the eyes because they're quite deeply sedated, and then we'll get a nice echo. And if we need to top up, I find that initial combination generally buys me time enough to echo, but sometimes someone who's a bit slower, a bit less experienced, a bit more thorough, I don't know, they'll take a bit longer, and therefore you need to top up with some IV alfax. And we tend to just do 0.5 mg per kg per top up in those cases. And that works quite well. And they recover quite quickly, and they can go home, a couple of hours later. And the midazolam is quite good because it has an amnesiac effect. So they sort of forget the wind up and the terror of coming to the vets. So it doesn't contribute to that progression of stress and anxiety. If we are going to see them annually for repeat echo, it doesn't mean they sort of remember you torturing them the previous year. And actually their perception of it is just a little better. That's my theory. But I think it does help. So that's kind of my extreme sedation. The common one we use is just gabapentin, and that is pretty cardio neutral as well and very safe for animals. All of these combinations are very safe for animals with even bad heart disease, I think. And the only effect I can think of really on the cardiovascular system to worry about or to think about is the alfaxalone after you top up will push the heart rate up a little bit. So I'm just a bit wary about timing some of my measurements. If we've just given a top up of alfax, I'll get some other measurements, and then I'll come back and do the Doppler measurements maybe when the heart rates come down a little bit and that alfax has worn off. Do you have a similar approach?
Yeah, absolutely, absolutely. And I think gabapentin, as you were saying, is really a game changer. It helps a lot with traveling. There are some nice data out there showing that has a minimal effect on echocardiographic variables. So very, very safe. And as you were saying, then just to top it up with a bit of butorphanol, potentially alfaxilone, will help a lot. Totally agree. I just wanted to stress that drugs that everyone that does echo and likes hearts hate are medetomidine and ketamine, alpha-2 agonists and ketamine. We would avoid them by all means. Again, there might be situations where one or the other might be useful, but as a rule, we avoid them at all. We hate them, really. And so even in a very nasty cat, as you were saying, we should avoid those drugs and try to play with safer options, which are the ones you mentioned.
I think with the alpha-2s, some people use them and say, we gave the alpha-2s and then we found a heart murmur. And then we reversed them. So can you echo now? And that's challenging for a couple of reasons, because first of all, alpha-2s will increase preload, they increase afterload, that they drop heart rate, that they'll cause such changes to cardiac dimensions that not only is the echo inaccurate, but they can generate heart murmurs. They can generate mitral and tricuspid regurgitation. So if you detect a novel heart murmur in a dog or a cat that's sedated with an alpha-2, forget about it and auscultate them when they're, a few days later, when it's all out of the system. The other thing is that whole, we reversed it with the atipamezole and can you do an echo now? Because the animal's quite conscious and awake and looking at us. Well, the problem is that we know from some data that's out there that it takes about 36 hours for the echo to normalize even after reversal. So once you put alpha-2s in the same postcode as these cats or dogs, you can forget about an echo today or tomorrow. And most cardiologists are going to say, come back in 2 days and we can have a conversation about what the heart actually looks like. So I think that's probably an important thing to consider if you are using this sedative in combination for other work, for orthopedic radiographs or something. Just don't focus on these newly detected heart murmurs. Come back when there are a couple of days post sedation and review the situation then. Now that we've had a think about heart murmurs, cardiac biomarkers, and how to facilitate performing an echo, it's time for a break. This is a two-parter episode. There's so much to say on these early stage cardiomyopathies in cats that we're going to have a second part to this discussion where Jose and I are going to be talking about phenocopies, things which masquerade as hypertrophic phenotype cardiomyopathy. And we're going to think about how to stage cardiomyopathy and how to identify cats in the asymptomatic phase of cardiomyopathy that may benefit from treatment. So be sure to listen to that podcast to finish off this topic of cardiomyopathy in apparently healthy cats. And the discussion on managing heart failure is a whole different topic. And perhaps we can get a guest in to discuss that with us. So be sure to join us in episode 2 of The Animal Heartbeat, and we will look forward to seeing you soon.